Morning, Malavika.
Good morning, Sanjay.
Good morning. Good morning. How are you?
I'm fine.
Great.
Still fighting.
Malavika, I can't see your audio. Would you connect with your audio, please? Good morning, Malavika. Can you hear me?
Yes, sir, I can hear you, sir.
Okay, right. So this is good morning. This is Dr. Sanjay Bakshi. We are together today. We'll wait for Professor Saha to join and then we'll start. Is that all right? Okay. It's going to be like you're being taken for a ward round, and what we'll do is we'll go through the entire process of question and answers. I'll show a ward round patient, and we'll work our way through post-op nutrition and all that there is to it. Time permitting, we'll possibly go in for some bit of a recent advances. Okay?
Sure.
Thank you. Milind, I can see that you've joined. I'm having
Good morning,
a bit
sir.
of good morning. I'm having a bit of a connectivity issue, but I've got because my broadband is down for the last 4 or 5 days. But I've got a remote dongle and hotspot. So just in case we have a problem, just allow me to switch if necessary. So I've got both of them.
Sir, but I have not received the PPT from you.
So I thought because I was working till late last night.
Okay, sir.
I ran it on the dongle and on the hotspot both, and they seem to be working fine. So, we'll see.
Right, sir. In case there's a problem, I'll share it from my end.
Yeah.
Thank you, sir.
Thanks.
So we are just waiting for Saha sir to join.
Yes, of course. We'll wait for Professor Saha to join and then we'll start.
Good morning, Dr. Devakshi.
Good morning. Good morning.
Morning.
Good
Sorry.
morning.
Yeah. So
What we'll do is we'll start right now. I'm just going to open up the presentation.
yeah. So good morning. Today it will be a ward-round scenario discussion. Nutritional management is very important in surgical patient, and we may have a ward-round scenario of patient waiting for surgery or patient post-op, and then how do you address the nutritional part of this patient management. Dr. Sanjay Debakshi from AMRI Hospital will moderate the session today, and Dr. Malvika Rao, who is a second year junior resident at Apollo Hospital, will present. Dr. Debakshi, you can start.
Okay, thank you.
The scenario.
I hope my screen is visible.
Yes, yes.
Okay. Right. So that's the first slide, and Malavika will go through the process. So for a start, this is what I'm asking. Sorry. Yeah, there we are. So this was a 31. You've been on a ward round. You're giving our exams, or in a real life scenario. So do you want to read that? If we read that out loud.
A 31-year-old lady has a history of corrosive ingestion, presents with dysphagia and being maintained on regular dilatations for the past 6 months.
So that's the picture. So you want to read the picture?
It's a chest X-ray, PA view, which shows constrictions, which shows
It's not a chest X-ray.
I want to step in right now. It's not a PA view. Do you think it's a PA view? You can see the clavicles. That's the right clavicle. That's the left clavicle. That's the picture of the breast, and that's the picture of the other breast. So,
And there is some contrast there. There is some contrast there. You cannot say it's a chest X-ray. I won't agree. This is a contrast X-ray. You should pass on to the particular area of interest.
yes. So you must say this is a contrast study. So it's not a chest X-ray. It's a contrast study. It's not a PA view. So what do you think? Do you want to review your statement and
it's a contrast X-ray, most likely a barium swallow.
Yes.
Yes.
In a diagonal view of the chest, which shows stricture along the long segment stricture in the esophagus.
Okay. So why do you think it's a side-on view? And why not a carcinoma of the esophagus? Why do you call this a stricture? Why not a carcinoma of the esophagus?
So carcinoma of esophagus usually has typical apicor appearance with shouldering, which is not seen in this. This shows an entire long segment with irregular long segment stricture of the esophagus. Usually carcinoma will involve the lower or mid segment.
Okay, and why not why a side view? Do you think, can you help?
So because
Side view.
It looks rotated, like you said, the breast shadows are on one side of on the right side of the picture, and only one clavicle.
Look, what is this being shown? That's a vertebral column, isn't it? The picture is taken so that the crust doesn't overlap the column, isn't it?
Yes, sir.
If you had a carcinoma, as he said, you would have a street dilatation and shouldering. Okay, so that's the sort of narrowing you would have expected in a carcinoma. Okay, right. So now what happens is, recently after a difficult dilatation, she presents with fever, chest pain, and odynophagia, and a chest X-ray is presented. So I'm going to ask you, what are the findings? 6 months she's been on successful dilatation. Now suddenly she has this problem, and this problem is that of fever, chest pain, and odynophagia after the last dilatation. So I'm going to present the chest X-ray. Now you have this is a classic chest X-ray. Malavika, do you want to work your way through and tell me?
Yes, sir. This is a chest X-ray. It shows the costophrenic angles are normal, cardiac characteristics normal. It is well exposed with when well centralized. There is a shadow in the right mediastinum, which is most likely inflammatory in character, in nature, and so it's a widening of the mediastinum and most likely mediastinitis.
So tell me something, Malvika. I would like you to tell me what is this, let's take the, what are these two?
There's the classicals.
Great. CP angle is out here. The other CP angle is there. Okay. There's one border that I can see out here. Can you see that?
Yes, sir.
And I can see another border out here.
Yes, sir.
There seems to be something in there. What do you think? I mean, the radiologist has been kind enough to point this out. So what do you think?
Yes. So that's the mediastinum, which is widened. The first border that you do would be an overlap of the vertebral column as well as the heart shadow, and the second border seems more like an inflammatory.
So what is the color? You're looking at a chest X-ray. I'm going to point that out. What do you think is there? That and that seem to be the same thing, same sort of radiological status, Now suppose this patient presents with surgical emphysema in the neck. What do you think is happening?
Surgical, if the patient, I'm sorry, so there's a lot of noise.
Yeah, I know you're presenting from the hospital, so just, this patient presents with surgical emphysema in the neck.
Yes, sir.
What do you think?
The implication is that there's probably a breach of the trachea or the airways of the patient. This is caused airway capacity.
Okay, if we go back, Malvika, because we have an hour to discuss, so we'll see. I mean, this color, this is air, isn't it? Yeah. That is the color of air as well. And if you suddenly find surgical emphysema in the neck, it might be that the air is traveling up. So this is classic mediastinal air. Okay, now if I tell you this is mediastinal air, I'm going to clear up all the drawings to make it more obvious. Okay, so what do you think has happened?
Post-dilatation.
Post-dilatation, there is probably a rupture of the esophagus because this is a difficult dilatation and there is multiple strictures. It has caused a rupture of the esophagus and caused air into the mediastinum.
Okay, right. So that is mediastinal air. It's a perforation. Okay. Now don't forget this patient has, normally if you have perforation, it escapes out into the lung fields, isn't it? It hasn't done that. Don't forget this is a corrosive stricture of the esophagus, 6 months of dilatation. So what happens if you have, think about the sort of surgery you do for a corrosive stricture. Do you try and resect the esophagus? Is it easy to do that?
No, sir, it's not easy to do because the patient.
Why is that? Why is that?
Most likely the patient have had difficult, after corrosive intake, also the chest condition will be poor. So the patients will not be able to tolerate thoracic surgery.
Right, Malavika. What happens in a corrosive stricture is that the inflammation doesn't restrict itself to the mucosa. It travels transmurally. So you have huge amount of periesophagitis. So because she's had a perforation in a patient who's had a corrosive stricture, it didn't escape out into the lung and it only escaped out into the mediastinum and up into the neck. This is an actual patient who was given to me by Dr. Sanjay Mondal. Okay, so you can see that this is a localized perforation, something you won't have in a de novo if you're doing an endoscopy and you have a perforation in a patient who doesn't have a corrosive stricture. The there would be much more widespread inflammation. Okay, so it's a localized fracture, right? So there we are. So she's found to have a localized esophageal perforation on a CT scan, which responds to conservative treatment. Fortunately, as I said, this is the rationale for treating it conservatively because she has a localized perforation. Then orally, IV broad spectrum antibiotics, intravenous fluid, and an initial parenteral alimentation. Now we're getting into the nitty-gritty of nutrition. Now, which route and why?
So if the patient has just, this patient is 6 weeks post, 6 months post callosal stricture, so we have to start with if the patient is able to take in
No, background of perforation. Background of perforation.
Oh, okay. So in background of perforation, we would it's contraindicated to give any enteral nutrition, at least by contraindicated to give oral enteral nutrition. We should.
Malavika, she has a localized perforation. You can't give her anything orally. Okay, isn't it? So you need to find alternative ways. And initially, because she has infection and everything, it was initial parenteral alimentation. So what do you mean by parenteral alimentation?
Via the central route or central.
Via central route. Excellent. So which route would you choose and why?
So because the patient will require long-term nutrition, it is preferable to use a central access, which is by a subclavian vein or by the internal jugular vein.
Okay, so you say either. If I tell you to choose one, which would you choose?
I would choose an internal jugular vein.
Internal. Okay, because I'm going to show you a picture which will give you the reason why you would choose an internal jugular, and that is the picture. Now you read that picture.
So this is chest X-ray, which shows right-sided pneumothorax, which is
right-sided
pneumothorax, which shows.
Why do you think the patient has had a pneumothorax?
Because while doing the subclavian line, it's very high chances of puncturing the apex of the pleura, apical pleura, which causes pneumothorax.
Right. So now you notice, can you notice some, I'm going to show you something. So you tell me what these are. What do you think these are?
The chest leads.
Chest leads. Any other shadow that you can see? Perhaps can you see another shadow out here?
So that's the subclavian line.
That's a subclavian line. So this is your argument. You've already got a patient who has air, mediastinal air, and you add another air out here. Okay, you can see that there's absolutely right. There's a pneumothorax on that side. So you don't want to add insult to injury. You've already got mediastinal air. So you don't want to add another problem to the patient, which is why your choice would be an internal jugular. Absolutely right. Right side or left-sided internal jugular? And your rationale. Right. Why the right side?
Right side is easier to access. It goes it's usually the preferred side, and it will go directly into the right. It has a direct route instead of the left side. We should have a longer.
Is there anything else on the left side which we are rather concerned about, which you don't want to injure?
Left side also has the thoracic duct.
Very good, excellent. Where does the thoracic duct end?
Just below the clavicle.
At what point?
It enters into the superior vena cava.
Junction of what?
So you have essentially one vein out here, one vein out there, and your thoracic duct enters here. Okay, so that's the junction of the left internal jugular and the left subclavian. That's what Professor Shah was trying to tell you about. Okay, so it enters into the junction. So it's very easy to damage the thoracic duct. Okay, right. which is why you've chosen um, a right-sided internal jugular. Okay, right. Now, following this, the patient had a following procedure. And now you have presented this patient in the ward. I'm going to ask you, what was the procedure carried out? Her weight is 44 kilograms and she is 156 centimeters in height. She's lost about 3.5 kilograms in the past 6 months. So now I'm going to ask you how we would manage this patient. So this is what this patient has. Now you tell me, what is this?
So this is repeating Jejunostomy, most likely using a police catheter.
So the patient has already an intravenous paraparenteral line. Why do you want to choose a feeding jejunostomy?
So feeding Jejunostomy is always preferred because enteral nutrition is always preferred to parenteral nutrition. Enteral nutrition has the benefits that it is cheap, physiological, it maintains the gut mucosal integrity, and prevents bacterial translocation and prevents further complications like ARDS and MODS. So we would prefer to have enteral nutrition.
Absolutely right. So your preferred modality where you can access the enteral. Absolutely agree. What are the complications of a parenteral long line? You've seen one. We've already seen one.
Parenteral nutrition has first is catheter-related or access-related complications like pneumothorax, air embolism, then injury to the arterial structures like the internal carotid can be injured, and the sepsis, dislodgement of the catheter itself, and infection of the IV line, thrombophlebitis. If then there is metabolic complications of parenteral nutrition, which include hyperglycemia, hypoglycemia, hypocalcemia, hypomagnesemia, hypocalcemia, kalemia, and then there is for parenteral nutrition there is long-term complications which include hepatic
liver damage. Yes. Yes.
dysfunction.
Liver dysfunction and often damage. Right. Right. Now, I'm going to ask you, is her weight loss significant? She's lost 3.6 kilograms in the last 6 months, and she's 44 kilograms. So is her weight loss significant?
Sorry, 10% of the weight in 6 months and 5% of the weight in 3 months. So this would be, it's 3.6 in 6 months would not be ideally significant weight loss. Doesn't fall under
She's 44 kilograms actually. So
44.
what percentage? So
So 4.4.
moderate weight loss.
I'm sorry, I can't.
What is her BMI? What is her BMI?
44. I didn't see the.
44 kilograms, 156 centimeters. What is her BMI?
I'll have to calculate that.
So how do you calculate? Just tell me how you calculate.
Weight divided by weight in kilos divided by height in meters squared.
Square. Right. So let me tell you that, I mean, I'll help you out with the numbers. She is 18.1. Her BMI is 18.1. Okay. So that was my next question. So is that where would you classify somebody who's 18.1?
18.1 according to the European or the Western standards, less than 18.5 is underweight. But for Asian population now we're speaking as 17.5 as underweight. So she would be within the normal bracket. 17.5 to 24.9 is the normal bracket for Asian population.
Right. So there's a bit of a difference between her, difference between the BMI stats for European and Western data and for the Asia Pacific. So how do you measure her nutritional status?
I would measure her nutritional status by with a thorough history and physical examination. The history will include her dietary intake and the amount and the kind of food she's been having over the past 6 months.
So Madhurika, she's already lost 3.6 kilograms in the last 6 months, isn't it? So how would you, on the table, you've taken a history and she's got a corrosive stricture of the esophagus, hasn't been eating all that well. She's been on regular dilatations, but obviously that hasn't done a lot of good. She's lost 3.6 kilograms. Now, on examination, how would you, assess a nutritional state?
On examination, firstly, a complete physical head-to-toe examination. So for proteins, I would assess the mid-arm circumference as well as if there's any edema. For caloric deficiency, I would see the weight, BMI and the weight, which we already know.
Okay, now we go over it. Weight loss over 6 months, you're quite right. If it's less than 5%, it's mild. Moderate 5 to 10, severe is more than 10% weight loss. So she basically qualifies as a moderate weight loss, don't you think? So BMI, yes. So as you quite rightly said, what is the definition for BMI in the Asia Pacific region? How does it differ from the international definitions? And that's your Asia Pacific cohort. Though there's been as I quite agree that there's been a movement to try and make this 17.1. Okay, so but according to the Far East data, it's still less than 18.5. And the difference basically is the WHO criteria for BMI cutoff. The difference really is that you have a difference. You have something called a pre-obese and the Asian criteria. All the bariatric surgeons who practice in India and actually use this as a pre-obese, which is not there in WHO criteria. Okay, right. Now, how would you assess a nutrition? BMI, we've been that. You look at vitamin deficiency. Okay.
Malavika, I think you also should add a general appearance of the patient. When you look at the patient, some general appearance may suggest patient is malnourished, like malar prominence. If you look at the chest, the prominent ribs. So as a whole, a general appearance of the patient may suggest that patient is malnourished.
Okay. All right.
So the general appearance is a very important modality. Okay, so and you also look at vitamin deficiency. So tell me, what is this? The first one. What vitamin deficiency?
The first one is chlorophyll.
So which vitamin?
Vitamin B, B1.
Okay, well, basically riboflavin deficiency. What is this being shown? Congested and enlarged gums and spiral sort of lesions around the hair follicles. What are we looking at?
I think the gum, that's the inflamed gums could be scurvy, which is vitamin C deficiency.
Very good. Excellent. Excellent. That's scurvy. Now, this patient presents with this sort of a feature around the eyes and complains of night blindness.
That is vitamin A deficiency.
Vitamin A deficiency, absolutely right. And this patient now presents with scaly lesions of the arms out here. What do you think is going on there?
Dermatitis because of pellagra.
What sort of dermatitis would give you this? Yes, you're very close. Tell me what is the lesion?
Pellagra.
Yes, absolutely. Vitamin B3 deficiency, pellagra. Now you tell me, Malavika, there's another medical condition which sometimes presents with this. What do you think can present with pellagra? And why?
I didn't get the question.
There's a medical condition where the patient sometimes presents with pellagra.
I don't know.
Carcinoid. Can you tell me why?
Oh, because the patients have diarrhea, profuse diarrhea and carcinoid syndrome because of serotonin release. So
that's right. And 5-hydroxytryptamine uses vitamin B3 for production. So sometimes these patients can present with pellagra as well. Okay, right. Now you said tricep skin fold thickness. So we on the vitamin tricep skin fold thickness is right. How do you hold the arm? At a right angle, beside the body?
I'm not sure. So I'm not sure the
Okay,
exact answer.
right. So quickly, Malvika, because we are going to run short of time. Skin fold thickness are the following sites that are seen. We normally use the first, which is the triceps, midway between the acromion and the olecranon, with the arm held by the side. And you also sometimes use a subscapular, which is a diagonal fold 45 degree, 1 to 2 centimeters below the inferior angle. I'm giving you a complete thing. You actually just need to know the triceps, and perhaps the subscapular. You don't need to know the others on a normal thing. If you're, if you have somebody who, if you're doing well with nutrition, you're then going to be asked, what are the others? The chest and pectoral, diagonal fold between the anterior axial line, nipple line halfway in men, 1/3 of the way in women, abdomen, which is 2 centimeters to the right of the umbilicus, that's used. You also have a suprailiac, where a diagonal fold, natural angle of the iliac crest, just superior to the anterior axillary line, and thigh. Now, there's a reason why these sites important. We normally see just the skin fold, the triceps, that bit. But why? Do you know why these sites are important, and where, which particular nutritional assessment these are important?
No, sir.
Okay. What you basically do is, you can now use body density and percentage of body fat for both men and women. In women, you use the triceps, suprailiac, and thigh for women, chest, abdomen, and thigh for men. And the body density is used to measure the percentage of body fat. Right. Okay.
And Dr. Debokshi, I find one measurement, a tricep skin fold thickness, if it is less than 13 millimeter in women and less than 10 in man, is described as less than normal.
Less than normal. Absolutely right. So I think, Madhvika, that's something that you need to know. You need to know all about the triceps. You don't need to completely know about that, but just keep in mind that if somebody asks you, the rationale for doing various things is because you can use that for a body density and percentage of body fat assessment. Okay. So we've done that.
Yeah.
Mid-arm circumference. So how would you hold the arm now for a mid-arm circumference?
So the patient, the arm will be held comfortably to the side of the patient, and I will use the distance again midway between. Yes.
So you're
Midway
basically going to turn the arm at right angles and make the patient comfortable, so that the patient doesn't strain, because then if you strain, that you're assessing, what are you assessing with a circumferential measurement out here?
The muscle.
Muscle mass, absolutely. So the arm is flexed 90 degrees at the elbow, but not very tightly, because otherwise you get a false, you have the triceps and all the other muscles swelling up. So that is something you need to remember. So these are the, you need to remember BMI, vitamin deficiency, as Professor Saha said, the general look of the patient, the BMI, the vitamin deficiency, the tricep skin fold thickness, 13 centimeters for women, and Dr. Makulachat gave you the figures for the thickness that is valid for Indian men and Indian women, and the circumferential measurement with the arm fixed 90 degrees at the elbow. So what are the components of the feed, and what is the feeding schedule, and what are the complications?
Okay. So feeding, for feeding jejunostomy, once the procedure is done, first we'll have a trial. We will start free water through the feeding jejunostomy in a serial.
No. First calculate, Malvika, first calculate how much to give, and then you calculate what to give, because a trial is something you give before starting any feed. But before you go for this, you have to calculate the calorie requirement and then divide the calorie into different components of food. How do you do that?
How do you do that?
She might be septic, so we have to account for that first. First, we will calculate the requirement using the Harris-Benedict equation, which for men it is 65 into, I forgot the equation, but we use the Harris-Benedict equation, and we multiply it by activity factor as well as stress factor. Since if she is septic, then we will have to use a higher score, which is 1.6 to 1.8, and that is stress factor. And activity factors, assuming she is bed bound, it will be usually 1.1 1.0 to 1.2. You might, the basal energy requirement is calculated by Harris-Benedict equation, and we multiply it by stress factor and activity factor, and
So what
find
is
out
the thumb rule? How much of calories do you want to get?
We need a minimum of 400 kilocalories to maintain basal functions of the patient. That is corresponds to around 80 grams uh, of glucose, which we need given carbohydrates. The total caloric value in
How much of fat and how much of carbohydrate?
We give 60 to 70% of carbohydrates and 30 to 40% of fat.
Okay.
And protein is
So,
calculated.
Malavika, 400 is not the right statement. 400 you calculate for basic metabolic functions.
yes.
But this patient having a stress and other, it will not be 400. You have to calculate based on the body weight. The calorie you have to give for maintenance and also for building up, because she is waiting for some other interventions. So you should be, there is one calculation described that 30 into body weight in kg is the basal energy expenditure. And then you have to add up the stress factor.
Okay.
So you should be around 14 or 1500 kilocalorie in this patient if you go by body weight.
So, and the types are basically, you can use either a polymeric or a pre-digestive or disease specific. And as Professor Shah quite rightly said, calories, protein intake, proportion of lipids and carbohydrates, don't forget sodium, potassium, calcium, and magnesium. Okay. So that's very important. And as he quite rightly said, calories, 25 to 30 kilocalories per kilograms per day. That's maintenance. And obviously you're building up this patient for a bypass, a colonic pull-through bypass or something like that. So you have to add to that. Okay. Proteins. It's 0.15 grams of nitrogen per kilogram per day. If you divide that by 6 point, as quite rightly pointed out by Professor, the basic thing is 1 gram per kilogram per day of protein intake. And you're absolutely right. Lipids 30%, carbohydrates 70%. Sodium is 1.2 millimoles per kilograms per day. What is potassium?
Potassium is 1 millimole per kilo per day.
Okay, absolutely. What about calcium?
Calcium
and magnesium?
I don't know. I don't know.
Okay, calcium is 0.1. Just remember 1. This is 1. So 1 to 2 sodium, 1 potassium, 0.1 calcium in millimoles per kilograms a day. Okay. And don't forget magnesium. It's also the same 0.1, 0.2, 0.3 millimoles per kilograms per day. Okay. And you will start it off slow, but your target is that, this is the target. So you could, this is a sort of I've taken it from the dietitian's manual. The first post-op day, you don't give, you wait for a little while, you just give sterile water, 20 ml every 6 hours, but you start off from the second post-op day. You could, this is just a suggestion. This is one of the dietary suggestions. You give 20 ml per hour on post-op day 2, extend it to 40, post-op day 3, POD 4, 60, POD 5, 80, POD 6, you're reaching target values 100. So you can now play around with this according to the patient's body weight and the requirement that Dr. Professor Shah quite rightly said. Your target is to build up this patient. You could even go up to 1500 to 2000 kilocalories, but that's basically, just a suggestion. You have to sit down and calculate and do regular assessment of her electrolytes and a regular assessment of what is the other blood results that gives you a good idea of how your nutrition is going, monitoring.
Before that, Malavika, Dr. Bakshi has shown that the calorie come 70% carbohydrate, 30% from fat. Why don't you calculate protein for calorie requirement?
So protein, because firstly this patient is septic, so she's having visceral protein loss. So we have to supplement that specifically. Also,
so even if the patient is not septic, we don't calculate protein for giving calories. You use protein for bodybuilding and wound healing in a surgical patient. So this protein should not be counted for calorie because it will be burnt out. So you give the adequate calorie from carbohydrate and fat and don't calculate. Suppose you give 60 grams of protein. That is supposed to give you 240 kilocalorie. But you don't calculate that amount of calorie for the total calculation. We keep aside the protein separate.
Yes.
So you see, Malavika, what Professor Shah is saying, that is never taken into the calculation for the number. I mean, this part that we are doing, it is calculated for fat and carbohydrates only.
Yeah. Yes.
Because this patient has lost 3.6 kilograms. You know what she has lost? She's lost muscle mass. And that needs to be built up. You need to build up her plasma protein so that she can actually heal. You're planning for a fairly major surgery. You're planning for a colonic pull-through, for example. Okay. Professor Shah, any other comments before we go to the next one?
No, it's okay. If you are giving the FJ, sometimes this patient may have diarrhea. Why this patient may have diarrhea following FJ, and how do you address that?
So diarrhea following FJ can be because of it's dumping syndrome, where there is a high osmolar.
No, it's not dumping. It's not dumping. It's something else.
Not dumping.
What happens? You are giving some food which is teen food from
calories
the
are
market.
gradually being increased. Why is that?
These are hyperosmotic foods. You see, if you use the teen food available in the market, if you prepare at home, that is different. But if you're using some proprietary preparations, these are described as hyperosmotic feeds. Okay, so what happens? If you give hyperosmotic feed in the gut, what is going to happen?
There will be osmotic fluid pulled into the.
This imbibes water from the gut wall. So there is a risk for diarrhea because of hyperosmotic feeds. So in that case, you can dilute the feed. And if you feel that sepsis is also a component of this, because you are giving feed directly to the tube, so you should take precautions. So hyperosmotic feed is addressed by diluting the feed.
That's right. Starting slow and diluting the feed so that you don't land the patient with osmotic challenge. Okay. Right. So what are the complications of feeding jejunostomy? And Professor Shah quite rightly said we'll address the non-mechanical because Dr. Shah has already talked about that. What are the mechanical complications?
Mechanical complications include start right from surgery, during surgery complications like it's inadequately fixed, and there is leak from the site of.
How would you put in a feeding jejunostomy tube?
After preparing the patient for surgery, we can use upper abdominal transverse, left-sided transverse incision, or we can use an upper midline incision. We first locate, we pull up a loop of the jejunum and trace the proximal and distal segments. The proximally, we have to trace it up to the DJ flexure to confirm the proximal and distal side. Once that is done, we take a 20 centimeter, a minimum of 20 centimeters from the DJ flexure is site is chosen, and we make a nick in the lumen of the, in the serous.
Why do we use more than 20 centimeters?
Because the antiperistalsis is approximately goes up to 20 centimeters.
Okay, so that you don't have a reflux into the upper reaches, pancreas, and even into the stomach. Yes. Okay. Then what do you do?
Then we make a nick into the bowel lumen and dilate the segment. Then we use whatever conduit we are using. If you're using a Foley's catheter or T-tube or a Rice tube, we will check the patency of the tube. And if we're using a Foley's catheter, the bulb, and we've introduced the Foley's catheter into we take a first string suture around the opening that we have created, and then pass the conduit through the lumen, make sure that it's passing adequately, and we can use saline to lubricate the flow. Then we will ensure that that saline is passing through the conduit so that there's no obstruction while inside the lumen.
So inherently, what you've done, Malavika, you need to do a tunneling. Okay. What is that tunnel called? Do you know what the tunnel is called?
Visual,
where you actually invaginate.
it's called visual. I'm not sure if
What is that? What is that tunnel called?
sorry, sir.
It is.
This linear tunnel is what?
So it's called the Witzel's technique.
Yes, it's called the Witzel's procedure. And when you're fixing it to the abdominal musculature, you must make sure it's fixed at both points. You know, you bring the intestine up and you fix it continuously out here with the tube entering. You don't put a single point. Why don't you put in a single point? What happens if you have a situation where you've, perhaps that's the muscle, you brought up the intestine and you fixed it just at one point? What can
There's
happen?
a torsion happening for
Yes,
or body.
Yep. Okay, right. So that's it. So what we've done now is mechanical dislodge feeding jejunostomy. When I have a clogged feeding jejunostomy, a leak and intestinal obstruction, either by volvulus or you've made the tunnel too large, okay, because your tube was too large and you made it. And Professor Shah has already been through this total.
And
I mean,
one question, Malavika. You have a suspicion that tube might have been dislodged. What is the next step? Will you give a trial feed or you have something in mind? You have a suspicion that tube might have been dislodged.
So we can try repositioning the tube first and then starting feed. I'm not sure, sir.
No, you should do a contrast study. If you have some, because if you give a trial feed with a milk or something, it might leak in the peritoneal cavity. This happened a number of times. So if there is suspicion of dislodgement, you just inject some contrast through the tube and take a X-ray. It should be in the gut.
Okay.
and preferably a water-soluble contrast, isn't it, Professor Shah?
Yeah.
A water-soluble contrast, so that you don't want milk and anything, your feed floating around in the peritoneal cavity. And that is why you do that. If you suspect that, a dislodge feeding jejunostomy, do that. Okay, and so we've already talked about, fluid, the osmotic diuresis, but you have something also called a refeeding syndrome. What is a refeeding syndrome?
So when a patient has prolonged starvation, which is likely in this patient since she has restriction, is unable to take oral feeds for a long time. If you suddenly start high volume, hyperosmolar feeds, they can cause derangements in the glucose. Like
where would you suspect, in which cohort of patients would you suspect that this patient might develop a refeeding syndrome?
Patients who have had prolonged starvation.
Yes.
How long?
Chronic malnutrition. Yeah.
A period of chronic malnutrition. But what happens? What is the pathophysiology? You have an insulin level spike in response to your glycemia. Then what happens is your cellular uptake of potassium, phosphate, and magnesium. As a result of which, what happens if you have potassium depletion, phosphate depletion? What happens? There are two important moieties which drive cellular action, and these are the APP and the 2,3-DPG. They both need phosphate. If you don't have phosphates, they become, you have a problem, and then you land up with cellular dysfunction, respiratory and cardiac failure, and also renal hepatic failure, seizures. So that's a very, very major problem, Malavika. Sometimes people die. You start them feeding without realizing. So you need to, who are at risk. Any patient who has been starving for more than 5 days, any patient who has starved for longer than 5 days, you must keep in mind that they might develop a refeeding syndrome. So at what BMI would you suspect that this patient might develop a refeeding syndrome?
It's more common in patients of at extreme ends of the so undernourished or obese patients.
So that's a general statement. BMI, do you know what the BMI? If the BMI is less than 17, which is why the Asia Pacific cohort, there's been an argument against labeling it 17.1 because that is critical. So if your BMI is less than 17, Malavika, these are the patients who can develop refeeding syndrome. As a matter of fact, if the BMI is less than 14, you're going to need ICU care for keeping a check on cardiac arrhythmias. Okay. And groups at risk, chronic alcoholics, drug abusers, anorexia nervosa, bulimia, etc. Okay. So how would you manage this?
So we manage by making it, we manage conservatively by we replenish the we decrease the
How do you manage conservatively?
Do you give the full feed at the first go?
we
Do you
decrease
give the full feed?
No, sir, we don't give the full feed at the first go. We start serial validation or serial increments of the feed and see how the patient is tolerating. And we check for serum electrolytes at every alternate day to make sure that the patient is not going.
How frequently do you check the electrolytes and where you're suspecting a refeeding syndrome?
At least daily should be done, and daily or alternate.
6 hourly. Yeah, you need the care of an intensivist, so you need a perhaps an ICU setting for looking at this patient. Baseline potassium, phosphate, magnesium, and regular monitoring and replacement. And as Professor Shah said, initiate slow rate, 25 to 50% target, and you keep on monitoring electrolytes. 6 hourly sometimes. Sometimes achieving a full feed might even take as long as 72 hours. So Malavika, you need to remember that. So what is the definition of severe malnutrition? What about the European Society of Parenteral and Enteral Nutrition? That's the ESPEN guidelines. You know what the definition of a severe malnutrition is?
Sir, I don't know the exact definition, but
okay.
Less than
the weight loss more than 10%, 15. You've already talked about that, isn't it? You already know that. A BMI of less than 18.5. Okay. Preoperative albumin of less than 30 grams per liter, which is 3.0, with no evidence of hepatic or renal dysfunction. And if you do a subjective global assessment, grade C or an NRS grade more than 5, President, we have 10 minutes. Do you think we can talk a bit about the subjective global assessment and the NRS nutritional risk scoring? Prasad?
Yes, yes.
Okay. Yes. So this is the subjective global assessment. Malavika, you notice on the medical history, you're quite right. Nutrition, nutrient intake, weight, symptoms, functional capacity, and metabolic requirements. And you see, these are the assessment that you use where you have a seriously ill patient. According to the ESPEN guidelines, what you actually use are these. You are subcutaneous fat, and where do you see subcutaneous fat? Eyes, triceps, and trunk. Where do you see muscle wasting? We've already seen the mid-arm, but you can see it at the temple, clavicle, shoulder, scapula and ribs, quadriceps, and particularly the small muscles, the dorsum of the space between the thumb and the index finger. Okay. So these are and fluid assessment. You're right in saying, you mentioned once that how do you assess proteins? You assess it either by edema or the presence of ascites. Okay, so that's the subjective global assessment. Now, there you have initially either a well-nourished patient where there's no less than 5% weight loss, or you have a mild and moderately malnourished patient where you have a 5 to 10% weight loss without stabilization of gain, or a severely malnutrition, or a patient with cachexia and or sarcopenia. So that is the nutrition that's, quite dated. It's 2002. Initial screening is the BMI less than 20.5. If the patient has lost weight within 3 months, reduced dietary intake in the last week, is the patient severely ill? So if there's an answer to any of these questions, these are both the American and the European guidelines, you go to the second group, which is the nutritional risk scoring, also 2002, and where you have an impaired nutritional status assessment and severity of the disease. And if the patient is more than 70, you add 1 to the total score. So that is the age adjusted total NR nutritional risk scoring. Okay. You also have recently, and that has been coming in a big way. This is the Nutric scoring of 2001, where you use age, the Apache 2, the SOFA, which is the sequential organ failure assessment, and the number of comorbidities, days from hospital to ICU admission, also, and interleukin 6. These are the assessments. Okay, so that is the Nutric scoring. If you have a severely compromised nutrition, you have to do that. The other thing is, how do you define this thing called sarcopenia? Malatke, do you know what sarcopenia is?
No, sir.
It's coming in majorly into most surgery. You notice that particularly if you're doing major cancer surgery, you do that. It's a condition characterized by loss of muscle mass, strength, and function, particularly in older adults, but it can also occur secondary to chronic diseases. Certain group like cancer patients, chronic alcoholics, drug users are prone to this condition. There's loss of muscle, and that is an expression of how you can, how you respond to surgery. And because you people need to know, by the time we were training, it wasn't recognized in the ICD. Now sarcopenia is recognized as a disease with the ICD coding also.
Okay.
So how do you assess sarcopenia? You anthropometric prediction, assessment of muscle mass, and assessment of muscle strength, and assessment of physical performance. Do you know what? If you don't, I'll go ahead because we are running a bit short of time. Anthropometric measurements are mid-arm circumference, skin fold thickness. We've already done that. And you, in addition, you add a calf circumference to assess. This is the anthropometric assessment of sarcopenia. Muscle strength. This is very vital. Muscle strength measurements. We almost for all major abdominal surgery, we do that nowadays, and we document that. Grip strength. Use a dynamometer in dominant hand for 5 seconds. In men, it has to be less than 27 kilograms. In women, if it's less than 16 kilograms, then you've got a diagnosis of sarcopenia. Chair standing. Rise from seated position and sitting down again for 5 times. If it's more than 15 seconds for 5 rises, that qualifies as sarcopenia. Rising from a chair, walking for 3 meters and back till seated. It's called the TGUG, to get up and go. If that's a short form for TGUG, that's more than 20 seconds. So these are the 3 muscle strength measurements which are assessed. And in addition, you can use CT scan imaging techniques. For the chest, you assess that the erector spinae, and you see that in this group A, this A and B, this is a patient who had a very low muscle strength. In C and D, you have a far more robust, and you can see the response, the chest response to that. We are doing it regularly. We were doing it regularly at CMR and our previous hospital, and this was one of our DNB dissertations. Ali Kaifdani did that observational study on sarcopenia as an independent predictor, and we found a startling sort of response. Post-op test complications are far more severe in patients who are undergoing, who have sarcopenia, who are undergoing major surgery. And what we did was we do a cross-sectional area of the psoas muscle, and this is accepted at the level of the TL3 vertebra, measured by, because we are always, most of these patients have a CT scan, and you assess the area under the psoas. So if it's more than, if it's less than 3.74 centimeters squared per meter square, assess it according to the height in meters. So height in meters square divides the area under the psoas, 22.29 centimeters for females. As a result, and surprisingly, there's a study from Velo which has actually quantified that for Indian patients, So that's the psoas mass index. So we use that on a regular basis. There's another issue, which is dual X-ray absorbimetry. That is coming in a big way. If we have about 4 minutes for us, can I just go through the next few slides on
yes,
dual
yes, yes. Yes, we have 5 minutes more.
Yeah. So DXA consists of a whole body scan performed by emitting X-ray sources at two different energy levels, 40 and 70 keV. Radiation usually is around 5 microsievert volume, which is, what is this sievert? Do you know what the term sievert stands for, Manvika? That S. Sievert. Sievert is, I mean, normally when you have radiation that's measured with gray, sievert is the amount of radiation that is absorbed, So that shows how much a patient is getting radiation. So that's the sievert unit. Okay. So you do that, and I'll show you the next, which actually makes it. Measurement of lean mass, fat mass, and bone mineral content simultaneously. What is taken is for people who are really, now we are really entering territories where patients are really, really, really ill. So there's a sum of the upper and lower limbs lean mass. It's defined as the appendicular lean mass. So it's called ALM, is used to quantify muscle mass with the DXA. It's coming in a big way. And you can see that this patient who was younger actually had a ALMI of 6.37, and whereas this was 4.58. So she is sarcopenic. She is not. So this is the difference. A 40-year-old patient without sarcopenia, values above 6.0 kilogram per meter square. It's according to the European Working Group of people for older patients, status for older patients, that is version 2. In this image B, it shows an 84-year-old woman with a DXA-based diagnosis of sarcopenia, very low value, which is less than, less than 5. So it's 4.58. So this is the newer modality which is coming in. But sarcopenia clinical assessment of muscle strength, anthropometric assessment, then CT scan, then DXA. MRI and ultrasound, they're trying to establish it. It hasn't established. But I can tell you from this trial that we have our trial at CMRI, we had about 22 patients. I can tell you it correlated extremely well with the incidence of post-op complications. And we assessed it by, we had to take one modality because it was a DNB trial, and that was chest infection. And it was a very eye-opening sort of a thing, that DNB dissertation that Dr. Ali did under my supervision. Right, Malavika, any question about Professor Shah? Any other questions? Do you want?
No, we have extensively covered beyond the textbook. So a very comprehensive discussion on nutritional management. We have not touched the parenteral nutrition. We can take some other day, but we have gone into the basic concept of nutritional assessment. That is most important, because most of the students cannot answer. How do you say nutrition is average? But once you ask, how do you assess nutrition? That is a very extensive area. This can be asked even in a long case. So one should be very conversant with you may not be very knowing DXA, but at least you should be knowing the basic things of nutritional assessment. Another thing we missed is a total lymphocyte count is also taken as part of nutritional assessment. You say that if you have malnutrition, you have defective cellular immunity, and that can be assessed by counting the total number of lymphocytes. If it is less than 1500, that indicates you have deficient lymphocyte count, and that is a marker for increased incidence of infection in the post-op period. So we should take into account some basic parameters we can measure in our practice. Thank you very much, Dr. Debakshi. It was a very comprehensive discussion, and you have shown the other ways to approach a patient with malnutrition.
Because I had to finish by 9 o'clock. So
yeah. Thank you so much. Any question from any of the participants? It was a very comprehensive discussion. Malavika, you have answered very well.
You've done very well, Malavika. Good. Well done.
Thank you, sir.
Madam Banerjee.
Thank you. It was really nice.
Thank you.
All right. Thank you. Thank you.
Thank you. Okay. Thank you, Professor Shah. Thank you.
Thanks.